I'm Linnet Carty. Thank you so much for tuning in. And joining me today for our Medical Moments section is Dr. Zhiquan Zhao. Welcome, Dr. Zhao. How are you?
Good.
And babies, let's talk babies today. The first half is babies. The second half will be on bones.
Okay.
So tell us a little bit about what your last couple of weeks have been like.
I was on call once every week in the past 3 weeks, and I think the second time I had 2 babies, 2 deliveries, and the third time I had 3. Okay. The first time I had 1.
Okay, so new little people in the world.
Yeah.
And you had a difficult one at 26 weeks?
Yeah, I was standing by for a patient who broke her water 3 weeks, at 23 weeks, pretty early. Then she wanted to labor at 26 weeks. She had to have a C-section delivery because the baby was breech.
Wow, but baby's fine, mommy's fine.
Baby's fine, everybody's
That's great. It's always good news. So we're going to continue with our series. The last time you were here, we did first trimester questions. And so we're going to pick that up and hit second trimester questions.
Okay.
And I want to say thanks to all the viewers that sent us questions. So I'm actually going to read viewer questions, right? Is that okay with you? Great. So Holly from Bristol, she wants to know, how do you screen for abnormalities such as Down syndrome?
Well, actually we have quite some tools to screen for that. The first trimester screening can be done from 10 to 13 weeks. Involves ultrasound to measure the thickness of the back of the neck of the fetus.
Wow.
And the other part is some blood work, looking for different hormones in the blood, depending on the levels, and the results are based on the ultrasound findings and the blood levels. And someone will be given a diagnosis of whether she is screened positive or negative. Positive doesn't mean the baby is absolutely wrong, has certain disorders such as Down syndrome, but that means she's at risk, higher than the average population for that. Then the second trimester screening can be done after 15 weeks. Usually it's called quad screen. There are 4 different hormones looked for this testing. It's just blood work, and that also screens for the risks for Down trisomy 18, trisomy 13, as well as neurotube defect.
Okay. All right, we have Olivia in Windsor, and Olivia asks, what are some of the most common abnormalities in pregnant women for the babies?
Well, I think nowadays with really advanced screening technologies, we don't see a lot of babies born with certain disorders, but certainly common ones are Down syndrome, trisomy 18, trisomy 13. And neurotube defect is a disorder with a big, broad spectrum, anywhere with opening along the spine and the brain. Will be relatable under this category. One with
All right.
any.
So Liza from Bloomfield asks, what is amniocentesis? Is that the correct pronunciation?
Yes, amniocentesis.
And what is it done and what does it detect is what she wants to know.
Yeah, after somebody is screened positive for Down syndrome or any other concerning genetic disorders, the patient is usually offered further testing because the first trimester and second trimester screening tests the only screening tools. They are not diagnostic. So in order to make the diagnosis, amniocentesis is commonly offered to those women. Amniocentesis is a procedure involves getting amniotic fluid from around the baby. And this is done through a needle puncturing through the abdominal wall to the amniotic cavity, and fluid will be obtained. The fluid contains a lot of fall-off cells from the fetus, and the cells will be collected, and the genetic material will be obtained for analysis.
Analyzed.
Yeah.
Okay. So is there any risk to the mother or the baby getting that test done, and does it hurt?
I believe it's painful. It is real a painful procedure, but I think most women tolerate it well, to my knowledge. The risks, as you know, more advanced technology, the ultrasound technologies are available, the risks are actually going down significantly. Certainly risks for infection, leakage of fluid, even pregnancy loss are real risks, but the absolute risk is pretty low.
Good. Melina from Middletown wants to know, what is a cervical cerclage and how does it help women carry their babies to full term?
Cervical cerclage is a stitch that can be placed around the cervix. This stitch is rarely indicated for women, but based on a study done in the United Kingdom, women who have at least 3 pregnancy losses in the second trimester due to painless dilatation of the cervix are offered this type of procedure called cervical cerclage.
Which means they can't carry the baby? Or
that means, yeah, it's called cervical insufficiency. Their cervix will dilate without any contractions. So this so-called painless dilatation of the cervix. And of course, they're going to lose the pregnancy when the babies are really too young to be born.
So I know some women are committed to bed rest after 4 or 5 months or whatever. Is that why?
In some women at really high risk for preterm deliveries, bed rest is recommended. However, this is not evidence-based medicine. We provide recommendation. However, just no evidence that bed rest will prevent preterm delivery from happening.
Okay. Great. Now we have another question from Ming, and she's from Farmington, and she wants to know, what does a weekly injection of progesterone do?
17-hydroxyprogesterone has been studied extensively and has become a star out of so many different agents offered to women in attempt to prevent preterm deliveries. And based on the study, women with a history of preterm deliveries, meaning delivery of the baby under 37 weeks, who received the weekly injections was shown to have 40% reduction in the risk for preterm delivery again. And I guess it's huge. So since that study, it is recommended that women with a history of preterm delivery should get the weekly injections to promote, to increase their chance of having a term pregnancy.
And where do they get that injection? In their arm? Or
well, in theory,
belly?
it's injecting into the muscles, so usually on the arm.
On the arm. Okay.
Yes.
Very good. All right, as we wrap, we have 2 more questions. Sarah in England wants to know, what is an anatomy ultrasound, and what are the benefits of having it done?
Anatomy ultrasound is usually done in some places. It's also called 20-week ultrasound. However, in many different bigger institutions, it can be done around 17, 18 weeks. It involves really very close look at the fetus from head to toe, and all the anatomy, different structures are looked at to make sure that everything looks normal. Sometimes how many digits, how many fingers, toes can be counted on the ultrasound.
And of course, you can tell the sex then too.
Usually that's the time when the gender can be identified.
Okay, all right, and our last question before we wrap, this segment is Eileen from Jamaica asks, why do you screen for diabetes in the 2nd trimester?
Gestational diabetes is not very common. It's usually up to there's a 2 to 3% risk for most women during the pregnancy, and it's screened because whether a patient with diabetes or not matters so much in terms of fetal development and risks. It's usually screened around 26 weeks, 24 to 28 weeks, depending on one's risks. If somebody has a high risk for gestational diabetes, screening can be done sooner, even before 20 weeks.
Great. All right. Well, thank you so much, Dr. Zhao. Really appreciate it. If you have a question for Dr. Zhao, please look at this email right here. You can email him at medicalmoments@hotmail.com. Once again, send your questions to medicalmoments@hotmail.com. So stay with us. We'll be right back, and we will talk to the bone doctor. We'd have the bone doctor here, and he is here. He's fabulous. Please join me in welcoming Dr. Kenneth Alleyne. Welcome, Dr. Alleyne. I'm fine. Now I'm fine. Now that you've taken
That's
care
right.
of me.
Now that we have that knee all straight for you.
And bend my
That's right.
knee,
That's right.
and I'm getting back to business.
Good.
So welcome. Thank you for coming.
Thank you for having me.
And tell our viewers what inspired you to be an orthopedic surgeon.
Right. Well, I guess there are a couple levels to that. First, my parents are from the Caribbean, so there really weren't many options.
School, you gone to
right.
school?
You
Right.
boy, I mean, boy, I thought touch the books, yeah. So that was a big inspiration. But then it really was my grandfather. When I got to med school, I had no idea.
Mike Reed?
Michael Reed, that's right. Good memory.
Oh, yes.
Good memory. When I got to med school, I really didn't know what I wanted to do. But I always had an interest in putting things together, because my grandfather was a carpenter and had a carpentry shop, and I used to work with him a great deal on his carpentry. And we'd do things around the house, and down in the basement we'd build things. And when I got to medical school, I realized that's what I enjoyed doing when I rotated on the orthopedic service. Nice. We put things together, right? Bones are broken. We use drills and hammers and screws to put them all together. And
needles.
And needles, that's right, and you know about that. And based on that, I decided that I would pursue orthopedic surgery.
Sweet.
So that was my inspiration.
Tell everybody about the path that you've taken, including doing some time at Harvard and Yale and all those good places.
Right, sure. Grew up here, actually around the corner from here off of Homestead Avenue.
Yeah.
until we moved to Cromwell. Then my parents decided that I was having too much fun doing sports, and so they enrolled me at the Kingswood Oxford School, where I had less fun doing sports and more focus on the books. And from there, it was college and med school. I did a fellowship at Harvard, and then completed my residency, and then I did a fellowship in knee and shoulder surgery at Yale.
Sweet,
Yeah.
sweet. So the warmer weather is rolling around.
Yes.
And I know people want to hear, first of all, about some preventative things, especially as we get older. The bone them just start mash up
Yeah, boy.
and crack and pop and all kind of things. So what are some preventative things we can do for those of us that we like to walk on the treadmill, we like to, use the elliptical, we like to bicycle, or all those types of things?
Sure.
What are some
I can always
preventative
tell
things?
when the temperature gets above 50 degrees because my office immediately gets more busy with people with general aches and pains.
Yes.
And what happens is we're pretty dormant often during the winter, and the weather gets nice and we want to be out and walk, or we're working in the yard, we're doing gardening, what have you. And certainly that's the opportunity for injury. And one of the ways to help prevent those injuries or lessen the opportunity is first start slow. You cannot have been asleep all winter and then decide you're going to go out and run the Boston Marathon.
Yeah.
2, really involve yourself in a good stretching and flexibility program before you start your activity. 3, warm up, warm up, warm up. That's really very important. And 4, ease into whatever it is you're going to do. I mean, if you're a runner, start at a shorter distance and slowly build up. If you're a walker, don't necessarily try to go 5 miles the first time, and really listen to your body. When it's hurting, listen to it.
Listen to it.
No pain, no gain doesn't really apply when we're trying to be active.
Okay. What are the 5 most dangerous words? What are those words?
What is that?
it? Maybe it
maybe
will go
away.
away. 'Cause
Maybe
I say
it
that
will
all the
go
time, and I
away.
know viewers that
That's
say
right.
that all the time.
Maybe it will go away, and often it does. My general rule for my patients in my practice, and my practice is kind of, from 8 years old to 98 years old, is 36 to 48 hours later, if it's still hurting, probably should get evaluated.
Okay.
Most general aches and pains go away within a day or 2. But if it's persisting and your activity is limited and you really can't do the things that you'd want to do, or that pain just has not decreased, you might as well give us a call and let us
Okay.
take a look.
Now, I know people at home are like me, because I still get confused. All right, I hurt my knee. My knee got this big. I mean, there was no skin left to stretch. Okay? So, ice, I know that when
Right.
you first heard
That's
it.
right.
But after a week, is it still ice, or is it heat?
Yeah,
or
that's
what?
a very common question, exceedingly common question. Generally, for the first 48 to 72 hours, ice. And we tell people 15 to 20 minutes on, 15 to 20 minutes off, okay? And elevation if possible.
Okay.
After that, heat is really more helpful because now we're trying to get into the healing phase. Ice is for the inflammatory phase or the acute injury. Now we're trying to heal. We want to encourage blood flow. We want to start stretching and strengthening, and the warmth really helps with that.
Okay.
So heat.
So, what's the most popular? Is it the knee injury?
I would say knees are probably 2 to 1 to the shoulder. My practice is 90% knee and shoulder, and knees are probably about 2 to 1 to the shoulder.
Okay,
Yeah.
because that was me, the knee. I
Yeah.
fell on the knee, and it just,
Yeah.
and
Our knees take a
Wow.
beating. The average human being takes about 1 million steps a year. So,
Okay.
knees really, are under a lot of constant stress.
I hear my knee right now screaming, if you lose some weight, it'd actually be a little bit better. So what impact does weight have?
Another great
on your-
question, which is always
on your
very
knees?
sensitive in one's practice to bring that up, but it's important. 3 times your body weight goes through your knee, right? So
Right.
someone who's put 10 pounds on have effectively put 30 pounds on the
their
knee.
knees.
10 pounds off is 30 pounds off of the knee. I've had patients who are ready for surgery, and we get them to lose some weight, and they come back and say, it doesn't really feel that bad.
Wow.
They took off 20 pounds over a few months, and that's 60 pounds off of the knee, and that can make an enormous difference
Okay.
in how someone's knee feels.
All right, so I'm going to lose some weight. I've lost some weight. I'm going to lose some more weight. All right, so tell us about this whole athletic coach and soccer mom syndrome, and
Right.
what soccer moms can do to help.
Well, one of the injuries that I see over and over again are overuse in younger and younger children. When we grew up together, we went outside and just played in the yard, right? You came home, you put on your play clothes, you went
Yeah,
outside.
yeah.
No longer is that the case. The kids are on the travel soccer team, they're on the school soccer team, they're on the church soccer team, and these parents are just pushing them and pushing them and pushing them to the point where many very young children have injuries that could be preventable. And so, when we talk to the moms, we understand that they enjoy competitive sports. Well, I don't know who's enjoying it more, the kids or the parents, but nonetheless, there's an interest in competitive sports, but it has to be within reason. You have to listen to your child. Yes, some children are going to tell you it hurts when it doesn't hurt, but most kids are pretty straightforward. If it hurts, don't push them.
Okay.
And if it persists, bring them in to see your physician.
Yeah. All right, on the other spectrum, I'm very close with my dad, and he's getting older, and you know that he recently he broke his femur.
Correct.
Had a spiral
fracture. Yeah,
fracture.
it's a pretty bad injury.
Pretty bad injury. And we're going to throw up some x-rays for you to speak to, so I'll let you speak to those and tell me what those look like. What can older folks do to help prevent some damage to their
the short-term things that I tell elderly patients to look for is around the house. Where are all the dangers? For some reason, a lot of seniors love loose rugs in front of the sink in the bathroom. They just love throwing those little tiny throw rugs around.
Yes.
Those if you love those things, they need to be double stick taped or nailed down. I see more women, particularly women, with hip fractures in the middle of the night that I get called in to have to fix because of things that were really preventable, like that rug, like the door jamb that's raised, not having appropriate railing on the stairs, or a runner on the stairs that's not appropriate. So those are some things around the house that can really affect how someone lives and their opportunity for injury. Outside of that, elderly people, balance and strengthening is very important. Tai Chi has become very popular for seniors because it's all about strengthening and stretching and keeping their balance. You keep your balance, you're going to fall less. You fall less, you're going to break fewer bones. The most recent data shows 1/3 of women or patients who break a hip are not with us a year later. They die for a lot of reasons. So it's very, very important. And it's really a public health and public safety issue that we're trying to get out there for our patients.
Okay. I have a friend that she's going to need a knee replacement, which I think eventually I might need myself. Talk a little bit about what that entails. And
I think I know this friend.
Quick is the, I think you do too. And how quick is the recuperation period and all of that?
Sure. Knee
can we still kick our men
Yes.
afterwards?
Oh, yes.
Okay.
Absolutely. And sometimes I have women ask me for a special kicking knee. But that process has really improved tremendously over the last several years. Generally, patients come into the hospital. For me, the procedure takes about 45 minutes to an hour.
That quick? Wow.
Yeah. Well, we do a lot of them. So when you get it down, and we have a team that we all work together, and you really want to go to a place that's what they do.
That's what they do.
And that there's a team that's really focused on that. So 45 minutes to an hour for the procedure. Most of my patients are in the hospital 2 to 3 days. After that, you'll go to a rehab center. In the short term, we're doing really great things with pain management now, where most of my patients wake up and they're having no pain because we're able to put medication around the major nerves that go into the leg so that when you awaken after the surgery, you have minimal to no pain.
Oh, that's nice.
And then as that wears off, we can transition you to other medications, but the most painful time is really well managed now, and it didn't used to be. Most of our patients are up and walking the next day, if not the same day. They're starting to walk with physical therapy. Wow. And as I said, after those 3 days, you can either go to a rehab center or you can transition home with a physical therapist.
Okay, sweet. So what's new in injury prevention?
New in injury prevention is this recognition of the role that stretching, strengthening, and balance play in preventing injuries. We really didn't have a great handle on that previously, particularly in our senior patients. But by getting them to really focus on balance, to focus on stretching and strengthening, and this stuff they can do in a chair while watching television or while reading the newspaper. There are exercises that our seniors can do that can really help to prevent injury, and that's been the main focus, and it comes all the way down to my athletes in my sports medicine aspect of my practice. The focus on a good stretching and strengthening program as a way to prevent injury has really been amazing in our ability to take care of athletes. So
are surgeries any different for men as they are for women?
No, there are some things that we see differentially.
Like
ACL injuries, anterior cruciate ligament, which is the major ligament, mostly women.
What?
Yeah, in the NCAA, 10 times higher rate in women than men.
Why?
Because remember, what are the names in Connecticut knows when it comes to knee injury? Rebecca Lobo, Shea Ralph, right?
Yeah.
Two big names, both injured their ACLs multiple times, and it's indicative of what we see from very young ages, particularly with this overuse. I see 3 to 4 to 1 in my practice. Major knee ligament injuries in women than men. And now we do some of our surgeries. Our knee replacement, we generally use a replacement shaped for a woman versus one that's used for a man.
Wow. Okay. That's not what I expected to hear, but all right. So for those of us that love to go to the gym, there are a lot of people that don't. And can people really stay fit without belonging to a gym?
Absolutely.
Having a trainer and all that kind of stuff?
Don't need all that stuff. Very, very simple things. A good rug, a soft surface, some ankle weights and exercise bands that you can get at a local sports store. You can really set yourself up to do a very good workout. Certainly we want to increase heart rate, and that can be something you can do by just running in place, right? And other sort of plyometric or stretching and strengthening exercises can easily be done at home. A lot of information out there on the internet and a lot of books. You can go to Barnes & Noble and find out how you can build a very simple gym in about an hour in your home. That'll be very effective.
Okay, cool. All right, so now we've got up a little x-ray here, and it's of the lower part of the broken leg.
Right.
Can you speak to that a little bit?
Sure. That is a tibia fracture, and I just saw 2 last week. It's a very common injury from motor vehicle accidents or high falls. This gentleman, for some reason, put his ladder up against the house and didn't recognize that he put it on a bunch of leaves. And so as he was 1 story up to try to clean his gutters, ladder goes out, he goes down, and he sustains an injury that looks just like this. Something that's treated as an emergency certainly needs surgery, and what we generally do is put a pin right down the center of that bone so it lines up. As you can see, that bone is kind of at an angle. Right, so we put one right down the center, 2 screws to hold it in place beneath the skin, and about a week that patient can start to walk on that leg.
Okay, and then we just have one more, and it's actually a picture of that football player that you see with his one leg facing down and the other leg
correct
facing up. What happened?
Yeah, that's not a good look.
Not a good look.
In sports medicine, we generally would say not a good look. That is someone who's essentially destroyed all the ligaments in their ankle, such that they've dislocated the ankle and the foot is now facing backwards, which is essentially it's a career-ending injury for that athlete.
Oh, poor thing. Poor thing. Ouch, ouch, ouch.
Yeah, that looks painful.
Yeah, it looks pretty painful. Okay, as we wrap up, let's talk a little bit about the rehabilitative process, going into rehab for a knee, for a hip, much like what my dad had, that whole spiral fracture to the femur. What is that like for folks?
Well, the rehabilitation, and I emphasize to patients, and by rehabilitation we're really talking about physical therapy.
Okay.
And that has to be something that patients really need to be mentally ready for. It's a lot of work. And the time you spend in therapy is really small. It's what you do at home, what your therapist instructs you to do. And that therapy often is more than just doing exercises. There are instruments and tools that a therapist can use that you just can't access at home. So a lot of patients get upset when you say I'm sending them to therapy. Well, I don't need to do exercises. Well, it's more than just doing that. But it's a commitment, and it's stuff that you have to do every day to try to get yourself better.
It is. All right, as we wrap up the segment, tell me a little bit about, I complained that you juke me in my knee. That shot. And what that shot was about, and it's not cortisone.
It's not cortisone. Very good, you remember. Yeah, we call it a cortisone injection.
But
very few doctors that really use cortisone anymore. What it is an opportunity to put medication right where the problem is. Instead of having you take it through the mouth and have it go through your entire body and potentially do some bad things, we'll put it right where the problem is. And it's mainly an opportunity to address pain and inflammation, which is the basis of much of what many of our patients are suffering from. So we'll take that little needle, put the medication where it needs to go, and hopefully that alleviates the issue.
It did. It burned for a little while first, and
we try to make it
as
painless as possible, but
by the second
it's
day,
still a needle.
Oh, I could stand up without having to, Thank you.
You're very welcome.
Thank you so much.
Thank you for having me.
How can people find you?
Eastern Orthopedics and Sports Medicine. We're in South Windsor, Bloomfield, and Tolland. EOSM.net on the internet. And 860-648-4480.
Repeat that number one more time for me.
860-648-4480.
Great. Thank you so much, Dr.
You.
Kenneth Alleyne. Thanks so much much for watching both segments. I appreciate you watching the show. We want to thank from the first segment, Dr. Zhiquan Zhao, and from the second segment, Dr. Kenneth Alleyne. We look forward to a wonderful holiday for all of you. Happy New Year, and we will see you on the next program. Thanks again for watching. I'm Linnet Carty, and remember, I love you more than I love cooked food.